When a patient presents with an oligo or polyarthritis along with systemic symptoms and elevated inflammatory markers, one may suspect that the patient has an autoimmune arthritis, of which there are three main types: rheumatoid arthritis or RA, seronegative spondyloarthropathies or SNSPA, or polymyalgia rheumatica or PMR. The specific diagnosis can be difficult to make due to overlapping features between these three types of autoimmune arthritis, although they do have typical features which can help secure the diagnosis. Rheumatoid arthritis is a systemic autoimmune disorder characterized by the articular manifestations of joint destruction as well as several extra-articular manifestations of the systemic disease. It tends to affect females more than males and has a predilection for young adults and middle-aged patients, although the subtype of late-onset rheumatoid arthritis, which can be difficult to distinguish from polymyalgia rheumatica, is also recognized. RA tends to affect the small joints, particularly that of the hands, which classically leads to subluxation of the metacarpal phalangeal joints, which leads to the classic ulnar deviation appearance in advanced rheumatoid arthritis. It also classically spares the distal interphalangeal joints. Joint destruction can also lead to finger deformities, such as the swan neck deformity and boutonniere deformity in the fingers and the Z thumb. There are also several other extra-articular manifestations of rheumatoid arthritis that can be detected on clinical examination and imaging. Rheumatoid nodules are commonly seen around joints, particularly the elbows, but can also be detected as multiple nodules within the lung parenchyma. RA patients can also develop serositis, namely pleural effusions, as well as pericarditis and pericardial effusions. The neutrophilic dermatoses are a spectrum of skin manifestations associated with rheumatoid arthritis, which are characterized by a dense neutrophilic infiltrate into the skin, resulting in various different appearances, such as an ulcer-like appearance in the form of pyoderma gangrenosum, or several small raised erythematous skin lesions along with fevers in the case of acute febrile neutrophilic dermatosis or sweet syndrome. RA patients can also develop splenomegaly and neutropenia in the syndrome known as Felty syndrome. And RA is also associated with the development of interstitial lung disease, particularly the nonspecific interstitial pneumonia pattern. The hallmark serology of rheumatoid arthritis is having an elevated rheumatoid factor and anti-cyclic citrullinated peptide, or ACPA. The presence of rheumatoid factor and or ACPA in the right clinical context is suggestive of a diagnosis of seropositive RA. If there is active disease, the C-reactive protein, or CRP, and the erythrocyte sedimentation rate, or ESR, will also be elevated. Although, as you can imagine, this is a non-specific finding in autoimmune arthritis. The second type of arthritis I'd like to discuss is that of the seronegative spondyloarthropathy, or SpA. And as its name implies, it has a predilection to affect the spine, particularly the lower lumbar spine and the sacroiliac joints, but sometimes also the cervical spine as well, and can also have small joint involvement in the hands and feet. The disease onset for SpA is typically in young adults and affects males more than females. There are four main subtypes of SpA, and these are ankylosing spondylitis, psoriatic arthritis, enteropathic associated arthritis, and reactive arthritis. As its name implies, ankylosing spondylitis typically leads to fusion or ankylosing of the spine in advanced disease, which can particularly affect the neck and lead to marked limitation in the range of movement of the neck, as well as ankylosing of the lumbar spine, with the classical bamboo spine appearance on X-ray. Psoriatic arthritis, as its name implies, is when the manifestations of SpA are associated with psoriasis although the psoriasis may precede or happen after the onset of the SpA arthritis. There are 5 subtypes of psoriatic arthritis which describe the affected joint distribution. These are the distal interphalangeal joint predominant subtype, the asymmetrical oligoarticular subtype, the symmetrical polyarthritis subtype, the spondylitis subtype, and lastly, arthritis mutans, which is the most severe form of psoriatic arthritis with severe hand and finger deformities and telescoping of the fingers. With psoriatic arthritis, there is usually evidence of psoriasis on clinical examination, typically in the extensor surfaces and also on the scalp. There are typical nail changes, including that of pitting in the nails, as well as more severe changes such as onycholysis. There can also be the presence of dactylitis, colloquially known as sausage fingers, which typically affects the fingers where there is high disease activity in the interphalangeal joint. When there is high disease activity, the inflammation in the joints leads to the production of a joint effusion, and this, along with the inflamed joint, leads to the sensation of bogginess when palpating the diseased joint. This is known as synovitis, given the synovium, which is the membrane which lines the joints, is responsible for the inflammation and the effusion. Similarly, tendon sheaths can also be inflamed, and this is known as tendinitis, which is painful on palpation. Together, the presence of tenderness on palpation of the joints or the tendons is known as tenosynovitis, and this represents active disease. The seronegative spondyloarthropathies can also have the same extra-articular manifestations as that of rheumatoid arthritis, as well as manifestations such as ocular inflammation, specifically episcleritis or scleritis, and erythema nodosum, which is a painful rash which is typically seen in the lower limbs and appears like a bruise, which represents a panniculitis. These manifestations are classically seen in the enteropathic associated arthritis subtype of SpA, where the arthritis and these manifestations are associated with the presence of inflammatory bowel disease. Similar manifestations can also occur after an infection, which is known as reactive arthritis. As the name implies, SpA is typically seronegative in that rheumatoid factor and ACPA are negative. SpA patients often have the HLA-B27 variant, and this can be detected through a gene test, from which the presence of HLA-B27 may help support the diagnosis of SpA, but certainly does not exclude it. SpA also typically responds very well to non-steroidal anti-inflammatory drugs, and this may be a key part of the history that helps point towards the diagnosis of SpA. The third type of autoimmune arthritis I'd like to discuss is that of polymyalgia rheumatica. PMR affects females more than males and typically occurs in an elderly population, with a higher incidence in Caucasians. It typically affects the large joints, particularly the shoulder and hip girdle, as well as the associated muscle bellies, hence the name polymyalgia rheumatica. PMR has a strong association with a large vessel vasculitis known as giant cell arteritis, which typically affects the vessels which ascend from the aortic arch to supply the head and face. The vasculitis of the affected vessels leads to a reduced distal blood supply, which can lead to symptoms such as jaw claudication, where the compromised blood supply leads to ischemic type pain in the muscles of mastication when they are activated when chewing food, visual disturbances when the blood supply to the retina is compromised, and headaches, particularly in the temporal region when the temporal arteries are affected. PMR typically responds very well to low-dose steroid therapy, not dissimilar to how SpA responds really well to non-steroidal anti-inflammatory drugs. PMR, like SpA, is seronegative in that the rheumatoid factor and ACPA are not detected. The only significantly deranged blood test in polymyalgia rheumatica is that of a significantly elevated ESR and possibly CRP as well. As mentioned previously, the elevation of inflammatory markers is non-specific and simply represents active disease, whether it be from PMR, RA, or SpA. Therefore, PMR is a clinical diagnosis which is made when patients present with the typical joint involvement and myalgia in the right demographic. So to summarize, you can see that RA, SpA, and PMR do have some overlapping features, but they also have several distinguishing features which can help make one diagnosis more likely than the other and ultimately secure the diagnosis. We can now go on to discuss the typical features of the connective tissue diseases.